Hi, this is Brandy Babin with Mana Health Partners, bringing another educational series video to you. This time, it's on billing requirements. As part of Mana's ongoing commitment to elevating the standard of care across all Aspire skilled nursing facilities, assisted living facilities, and beyond, we provide videos based on CMS and Medicare guidelines to help with documentation and compliance. Our goal is to set the benchmark for excellence, inspiring others to rise to meet the high standards that we uphold. Together, we are making a meaningful impact, not only within the Aspire community, but also in the broader healthcare communities, where our presence is felt and our influence continues to grow. Today, as we discuss billing requirements as outlined by CMS, you may find them to differ from facility practices you followed in the past, or from what you've learned in your time in skilled nursing facilities. As such, some processes may need to be unlearned and replaced to ensure compliance with current CMS guidelines. Our objectives today are at the end of this presentation to be able to comprehensively understand billing codes or CPT codes, to review CPT codes and understand when to use primary or evaluation management codes 99310 and 99309. And then we're going to review time or MDM documentation, including snippets. Leveraging snippets or dot phrases to streamline documentation for both time-based billing and MDM billing methods not only help the note, but it also adjusts it to be more personalized for each additional patient. Accurate medical billing and coding are critical for the financial health and legal compliance of healthcare organizations. They ensure proper reimbursement for services rendered, reduce the risk of audits, and help avoid repayment penalties or financial fines. By accurately assigning codes, healthcare providers ensure they are compensated fairly for their services and that claims are processed smoothly. This process also protects against legal disputes, as proper documentation linked to accurate coding serves as a defense in the event of audits or malpractice claims. Inaccurate billing claims can lead to financial instability, delayed payments, and potential penalties, putting both the organization and the patient care at risk. Additionally, accurate billing and coding are essential for maintaining regulatory compliance with CMS, Medicaid, Medicare, and other payers. These practices help healthcare organizations meet minimum documentation requirements and prevent fraudulent or improper claims that could lead to serious legal consequences. Efficient billing reduces administrative burden, speeds up payment cycles, and fosters strong relationships with payers, ensuring smooth operations. Accurate coding also supports clinical decision-making, quality reporting, and research, ultimately contributing to improved patient outcomes and the overall success from the healthcare organization. So this slide discusses medical decision making. And should you decide to use medical decision making while you're doing your documentation, you're going to either meet the criteria of a 99309 or a 99310. We'll go through the 99309 first. It's a moderate degree of medical decision making, and it has to meet 2 out of the 3 elements. So here's 1. Here's 2, and the risk of complications is the 3rd. So 2 out of the 3. So the first one we're talking about, do they meet criteria for 1 or more chronic illness with an exacerbation, progression, or side effect? Do you have 2 or more stable chronic illnesses? Do you have 1 undiagnosed new problem with uncertain prognosis? 1 acute illness with systemic symptoms, or 1 acute complicated injury? If you have any of the above, including 2 or more stable chronic illnesses that not only you're going to put under your assessment and plan, but put underneath your HPI, you've already met criteria for this one right here. The second one is the amount or complexity of data to be reviewed. And in the moderate category, you need one out of the three categories. The first category is saying they want three things from you. They want you to review an external note. So that could be psych, that could be cardiology, that could be wound care, but you reviewing an external note. You can review a unique test. So that could be a CBC, a CMP, a TSH, any unique test, a Doppler. You can order a unique test. So any test that you need to rule that substantiates your HPI, substantiates your assessment and plan to rule out something or to get further information, or an assessment requiring an independent historian. So if you can meet three of those, you've met category one and you've met the criteria. There's also category two, which is independent interpretation of tests that were performed by another either physician or qualified health professionals that they haven't reported themselves already. So that's category two. And then category three, we meet every single time. Part of our standard documentation is to document that the patient's care has been communicated and collaborated with either the nursing staff or therapy or the dietitian. So we're consulting every single visit with nursing as well as potentially other providers in the facility. So we automatically hit category three every single time. Now, this is saying one out of three. So if we hit category three every time, we can put this into our HPI and our assessment and plan. We can definitely document this, but category three automatically puts us in that criteria. And then the risk of complications or morbidity, mortality. So for a moderate risk, you can implement a prescription drug management. So that would be something other than your over-the-counter Tylenol, naproxen, that sort of thing, Mucinex. You could have a discussion regarding minor surgery or elective surgery. That doesn't happen too often in our case, but if you had a discussion, you'd meet criteria. And then a diagnosis or treatment that's limited by social determinants of health. And so very rarely do we have this as a problem because skilled nursing facilities are required to provide care to meet the needs of their patients. So if you meet category one and you meet category two here, you don't have to meet category three. You only need two out of the three, but putting prescription drug management in place definitely gets you this third category. Again, two out of the three. In order to meet I, you need to have a little bit sicker of a patient and require a little bit more documentation under both your history of present illness and your assessment and plan. So under the number and complexity of problems addressed, so that would be one or more chronic illness. And that illness is going to have either an exacerbation or a progression or side effects of treatment, or an acute or chronic illness that poses a threat to life or bodily function. So a chronic illness that is having progression would be diabetes. Your A1C is getting worse. Your blood sugars are getting worse. A chronic illness that poses bodily function problems. We're talking about chronic kidney disease that maybe the GFR was 40, now it's 30, now it's 20. At between 12 and 15, you're going to be getting dialysis. So at this point, our kidneys are shutting down. And so that poses a threat to bodily function. So meeting this is not very difficult. You can have just a very sick patient or a patient that's declining or whose medical diagnosis is declining. Under this, the amount of complexity or the data that we review, you have to meet criteria of two of the three. Again, hopping right back down to category three, we meet this every single time by discussing our patients and how we've assessed them and what findings we have with the nursing staff as well as potentially the physician, getting them involved, the dietitian, therapy, the psych NP, the wound and NP or physician, etc. So we meet that criteria every time. The others are meeting the other two categories. So you'll have to meet one more of these. So category 2, going in reverse order, we've met category 3. Category 2 is the independent interpretation of tests that were ordered by somebody else. Or category 1, you need 3 of the following. So you need to read that external note. You need to review a test, order a test, or have an assessment requiring an independent historian. So it's easy enough to meet category 3 because we do it all the time. Category 1 might be a little bit more difficult depending on if we have the documentation in place, whether we have labs to review and what those labs are, and whether we need more labs. So if you've got a patient with chronic kidney disease, we're not going to be ordering random lab tests just to meet the criteria. The criteria for the labs must be associated with what we're working the patient up for. So meet criteria of here. And then to meet this criteria is the high risk of morbidity/mortality. So we're talking about drug therapy requiring intensive monitoring, not Coumadin. So that could include gentamicin, vancomycin, daptomycin, things that we're reviewing intense monitoring for. It could be the discussion of any kind of major surgery, elective surgery, emergency surgery. The decision regarding hospitalization. If you have a patient that you are hospitalizing, you've got a sick patient. Based on that, they meet the criteria of a 99310. They have to have something going on that's either severe exacerbation or that poses a threat to them. And then transferring the decision to hospitalize meets that 2 criteria. So as long as you're documenting both of those, when you transfer a patient to the hospital, they should meet a 99310 every time. And then there's the decision not to resuscitate or to de-escalate care. So it doesn't necessarily mean you have to put them as a do not resuscitate. So if you have the discussion and they don't want treatment and they are a DNR, we can change them to a do not hospitalize. We can have conversations with them about what kind of palliative care, supportive care, comfort care, or hospice care that they could benefit from. If they're a full code, they need to have care, or they can transfer over to a do not resuscitate. A sick patient that is not getting care or treatment is going to end up ultimately becoming sicker and potentially having mortality and then causing CPR. So we don't want to have to do CPR in the facility. So if they choose to be a do not resuscitate, that can count as well. Utilizing snippets can be used for time or for medical decision making. A snippet, it's a short pre-written piece of code or text that's already in the computer system, and you're going to click onto it. Once you click it, you're going to have to adjust it, edit it, customize it, take words away, put words in to make it appropriate. Each section of the documentation has snippets. Billing is especially important because we want to make sure that when we're doing the billing, the snippets that are already in there are based on the exact CMS documentation that's required. So we're just going to add to that and adjust it to make it applicable. Excuse me. Templates have been made to include multiple answers, and then the intent is to add answers or to delete non-applicable answers. So again, just remember, we're adjusting our snippets as we go. So here's an example of the snippets for medical decision making. This is moderate medical decision making. So each one of these has a little blue with a plus sign. That is what the snippet looks like, but that's all you see. So when you click onto this, it will say the patient has one or more chronic illness with exacerbation, and it was labeled moderate exacerbation. So this is saying this patient requires a moderate amount of decision making related to one or more chronic illness with an exacerbation. So if we're looking at this, what is the one or more chronic illness? So we could put in parentheses congestive heart failure. We could put in parentheses chronic kidney disease. But add something. What is our chronic illness? This patient right here, moderate injury, MDM. So this is saying that the patient has one acute complicated injury. In parentheses, I would write right ankle pain. If they twisted their ankle, they've got swelling, they've got bruising. Now we're doing an x-ray on it and they can't bear weight. So we've got an injury and that it requires a moderate degree of medical decision making. We haven't sent them to the hospital. They don't need to be sent to the hospital at this point. We're going to work them up in-house. So it's a moderate. So we're just going to put behind complicated injury in parentheses, right ankle pain or left hip pain, whatever the injury would be. This says the patient has two or more stable chronic illnesses, which has required a moderate degree of medical decision making. It's moderate to two stable illnesses of MDM, medical decision making. So this you are going to document both under the HPI as well as under your assessment and plan. So what are those stable chronic illnesses? And then what are we doing about them? As far as high degree of medical decision making, there's one that says high admit. So it's a high degree of medical decision making that requires extensive care to review, and neglecting them could possibly end up in a readmit to the hospital. This one is high exacerbation. So high meaning high MDM, and then exacerbation. So the patient has a chronic illness with a severe exacerbation. So what is that chronic illness? Put in parentheses, congestive heart failure. Congestive heart failure with 4+ pitting edema, bilateral lower extremities, and 2+ JVD, all in parentheses. There's one that says the patient's at high risk for morbidity and mortality related to exacerbations of chronic condition. What is that chronic condition? List that on there. Time-based billing and documentation is usually how nurse practitioners do their documentation. There's two references down here, one from the American Medical Association, one from CMS, that describes how to do time-based documentation. And this was literally a copy and paste right out of the CMS manual. The only thing I did add was this blue part here. So everything else is copied and pasted. So the time that it takes you to do your visit. So preparation to see the patient, and I just put some of the things that I do before I go see a patient. I'm looking at their blood pressure log. I'm making sure that not only today's blood pressure is good, but for the last 2 to 3 to 4 weeks. Blood glucose logs. So the blood sugar was 101 this morning, but then when you go back and look at the log, it's been 400 all month long. We're looking at blood glucose logs. We're looking at weight logs. We're looking at any labs that have come in. We're going to obtain or review separate history. So if you're looking at the wound notes, if you're looking at the psych notes, if they came back from cardiology and they've had blood pressure issues, you're going to document that you've reviewed cardiology note from, and then whatever date that you reviewed it from. Performing the medical examination, that makes sense. Then counseling and educating the patient, family, or caregiver. Now, while we do that almost every single visit, documenting that we've counseled the patient or the family or the caregiver, and that all questions were answered and that they have no other questions and that they understand, is very beneficial. Put that in your documentation. Any medication, tests, or procedures that you're ordering has to be written in point-click care. That takes time to write the orders and put them in. So you get time. You get credited for that time. If you're referring them out, you have to write a referral in Point Click Care. If you communicate with other healthcare professionals via a secured HIPAA site, then that counts as well. Documenting in your electronic medical record. So when you go home and you document for the day, and then any results that haven't been reported previously, communicating the results to not only the patient, but the family, especially if the patient is incapacitated or has decreased level of consciousness or a low BIM score, we would definitely want to communicate what was going on to the power of attorney or healthcare surrogate. And then any additional care coordination, whether we're getting the DON or the social services, RD, that type of thing involved. For coding purposes, for coding all of the stuff we just mentioned above, it is a regulation that has to occur on the date of the encounter. So on the date that you see the patient, everything else has to be done. You can't do everything and then document in the morning and count part of that time of documentation spent. So if you see the patient, you do this whole workup, you do all of the documentation for the day. This potentially could take you between 30 and 45 minutes. That's why we're using time-based documentation, is because if we hit a 45-minute visit, then we get to take credit for that. Now, this isn't if you're slower or faster than anyone. This is an average. So if you're a little bit slower than most nurse practitioners, it's got to be what is the average for providers like ourselves. So when referring to CMS codes 99309 and 99310, which are used for subsequent nursing facility care, you would typically, and this comes directly from CMS, you would typically use time as the primary factor to determine the appropriate code, as these codes are primarily based on the amount of time spent with the patient. However, you can use medical decision making as long as you meet the criteria and you're within the same parameters. There are time-based snippets, just like there were for medical decision making. So there's the 30-minute, 45-minute, you've got an admit. It's just a snippet that says that you've done an extensive chart review on them, that you've spent time with a family. If you're using any type of dictation, iDictation, Google dictation, Dragon dictation, Mobius dictation, there's just a little snippet there. If you're referring a patient out to someone, use that. That counts as time. That helps substantiate. Additional snippets would be chronic illness that's progressing. And so you can use the progression snippet. It doesn't replace time or MDM. It's to be used with time or MDM. Patient is experiencing a chronic illness that is worse or that is poorly controlled. One thing that needs to be remembered, you get to use time or you get to use medical decision making, but you do not use both. You do not put medical decision making and time in the same note. So as we look at billing codes, your 99309 is a moderate. It's an evaluation and management, and it's described as a moderate. And so you can use the medical decision making of moderate or 30 minutes. That will be your 99309. You can use time or medical decision making. Same thing with your high. So if you want to use 99310 and you use a high degree of medical decision making, or you use 45 minutes of medical decision making, then you'd use that. I've also got discharge, CPT codes in here, advanced care planning, and smoking cessation. Those are on other videos, but just a helpful reminder for today. I hope that helped. I hope that helped with billing. Billing is a little bit tricky, but as long as you stay focused to time and do everything in one encounter, or you stay focused on medical decision making and follow the grid, I think it's pretty easy to be able to make sure that our documentation is substantiating our codes that we use for billing. So I'm Brandy Babin. I've got my phone number here. I'm bbabin@monahp.com. I'm here and available for you if you have any questions. Please don't hesitate to reach out, to touch base, to ask questions, and I will talk to you soon.